Diseases, Yanapoya Medical College, Mangalore. Our esteemed panelists for the discussions are Dr. Kavitha Saravu, Professor and Unit Head, Department of Infectious Disease, KMC Manipal; Dr. Ganesh Bhat, Professor and Head, Department of Gastroenterology, KMC Manipal; Dr. Vikas Suri, Professor, Department of Internal Medicine, PGM at Chandigarh; and Dr. Deepak Kumar, Assistant Professor, Division of Infectious Disease, AIMS, Jodhpur. Now I invite Dr. V.K. Vineeth and panelists to kindly come on to the stage for the discussion.
I thank Kavitha Madam, Moderator Sir, and Department of Infectious Diseases, KMC Manipal, for this opportunity. I belong to the neighboring district, Mangaluru, so these cases are basically from Mangalore. Before we go to the case per se, what is intra-abdominal infection? Basically, we can just classify into two simple terminologies. Is it complicated or an uncomplicated? How do we tell it is complicated? Complicated intra-abdominal infection extends beyond the hollow viscus of origin into the peritoneal space or otherwise sterile region of the abdominal cavity, and it is associated with peritonitis but with or without abscess formation. So this is the it's not petty. Excuse me. Yeah, sorry. So complicated intra-abdominal infection, it extends to the peritoneal space and is associated with peritonitis with or without abscess formation. This is complicated intra-abdominal infection. Now what is uncomplicated intra-abdominal infection? Uncomplicated involves only the intramural inflammation of the gastrointestinal tract without extension into peritoneal space and can progress. It can progress. It's like a disease in evolution if not adequately treated. For example, just 2 weeks back, I saw a case of pre-peritoneal abscess. It was not extending to the peritoneum, but it was an abscess. These are disease in evolution. Without much delay, as it's a panel discussion, it's a Sunday, so I will like to make it case scenario based. We have esteemed 4 panelists. To the case 1, 39-year-old female. She travels a lot, does a travel blog, travels all around India. To be frank, when I heard about our travel history, I was more thrilled than her. Okay, she's traveled all around India, abroad, and she presented with fever of 6 days. It was continuous, it was high grade, it was associated with chills. Okay, she had abdominal pain of 5 days. She denied any constipation or loose stools. She had loss of appetite, and she keeps a tab of her weight, so she had lost around 6 kgs in 1 month. On examination, her heart rate was 110, BP is 90/60, and the saturation was 98. Per abdomen, she had diffuse tenderness. Now, at this point, her BP was 90/60. She received a fluid bolus at the casualty, and her BP picked up to 110/60. What's the syndromic diagnosis? We ID physicians, before going to the reports, we try to put our clinical syndromic diagnosis. So let's go with the panelists. Option A will be acute cholecystitis. Option B, peritonitis. Option C, diverticulitis. Option D, pancreatitis. Dr. Vikas, sir?
Well, the history, if you say that the presenting complaints are acute onset, yes, that is 6 days of fever.
Yes, sir.
And about 5 days of abdominal pain. But you said that the patient has a loss of weight and loss of appetite for the last 1 month. So probably the history starts from about 1 month, so it's a subacute onset, and now the fever is there. If that loss of appetite and loss of weight was not there, my probably diagnosis would have been probably cholecystitis or pancreatitis. But because you have a history which lasts for, if that is significant history, that you say 6 kgs in 1 month, then probably my diagnosis would be shifting towards diverticulitis, or because pancreatitis, if you have to have weight loss, chronic pancreatitis has to be more than 3 months. It will not have fever. It will not have. So I would probably say diverticulitis, or if that history is significant. If you say that history is not significant, then my first diagnosis would be cholecystitis. Peritonitis, patient has to be very sick. The clinical the signs would have rebound tenderness. You didn't mention about the rebound tenderness on examination. And the BP improved after fluids. So if that history of 1 month is significant, my diverticulitis was, if that history is not significant, then probably cholecystitis would be mine.
Dr. Ganesh Bhat, you would like to add on anything, sir?
As a gastroenterologist, I want to know more about the pain and these things. Where is the pain? Certain tenderness. So for me, as sir told, pancreatitis and cholecystitis is very unlikely because starts almost 1 month back. So possibility of peritonitis and diverticulitis, and you are repeatedly stressing on that repeated travel, or maybe peritonitis also has to be.
Sure. You would like to add on, sir?
Yeah, because as you said, travels a lot, then definitely liver abscess could be one of the associated with would be a ruptured liver abscess, which could be a cause of evolving abscess that causing loss of appetite and weight. Now it's presented with the ruptured liver abscess with peritonitis, could be.
Sure, sir, sure. We'll continue with the case. These were the investigations. Her hemoglobin was 12. WBC count was 17,300 with the neutrophils of 80, lymphocytes of 10, monocytes of 10 without 0 eosinophils. Platelets were normal, creatinine was normal, total bilirubin was 0.8, SGOT is 62, SGPT 50, and alkaline phosphatase was 180. GGT was 100. This is maybe a day before presentation. These were the investigation. And this travel log has never checked her sugar. That is even more funny. And when she came, her GRBS was around 360 and her HbA1c was 9.2. So she is likely to be a diabetic patient who has been never checked sugars till now. Her lipase and amylase was normal. I have not added amylase, but both were normal. So now the question is, which investigation will go ahead? Okay, should we go ahead with an ultrasound? Should we go ahead with the CT with contrast? Should we go ahead with MRI? Dr. Kavitha, madam, your opinion? In this scenario.
I will first go with the ultrasound of
Okay.
the abdomen because some things which are very easily, which can be picked up, I would like to check. Maybe something like a liver abscess, we can easily check with the ultrasound. So I will, and it's no side effects. We don't have to use any contrast, ease of performing. So I think I would go with the ultrasound.
Ultrasound. So as ma'am rightly pointed out, we went with ultrasound, but unfortunately the ultrasound was done in an outside hospital during that time. Because majority of them, when they present, they already have some reports with them. This was the report exactly. It was showing a calculus cholecystitis. They had not mentioned any specific report of obstruction or collection or thickening. They have not mentioned it very clearly. It was just calculus cholecystitis. They had mentioned 8 mm, if I remember correctly, not more than that. And she persistently had a tender abdomen, diffuse but more predominantly in right iliac fossa. Hemodynamically she was stable, but she was on IV antibiotic and IV fluids. Now, should we at this point, as we already have an ultrasound report, at this junction, should we go ahead with ultrasound, CT abdomen, or directly shift to OT? So there will have 3 options. Dr. Ganesh sir. That's why I thought to make scenario little gastro related.
Yeah. So it's already more than 6 days of pain and already proven cholecystitis. I prefer to do an image CT with contrast. Unlikely that she will be shifted directly to the OT, because we have to characterize whether it's a complicated cholecystitis or a uncomplicated. That means either it's an empyema or it's a already ruptured gallbladder with a rhizomatoid collection. Ultrasound may not pick up those small things. CT may give a good idea.
So as sir told, sometimes they are hit directly to the targets, and this is the CT. As we can see, the arrow pointing towards significantly complicated gallbladder. I'll tell you the report. This is a contrast enhanced CT where gallbladder showed significant sludge with multiple intraluminal calculi with thickening, with focal areas of wall disruption and suggesting of calculus gangrenous cholecystitis. So we will categorize it to a complicated cholecystitis. So at this scenario, in non-pregnant adults, the suspected acute cholecystitis or cholangitis, if initial, as madam has clearly told, your initial modality will be still ultrasound, but if your initial USG is equivocal or a non-diagnostic, it is not adding more to your clinical judgment, you will go with abdominal CT. She developed new onset hypotension, minimal NORAD requirements. Now, what will be your antibiotic of choice? We'll go with Dr. Vikas sir. Option A, meropenem IV and directly take her to surgery. Option B, ceftriaxone with doxy. Option, continue the antibiotic and go ahead for surgery. What will be your call, sir?
There's a new onset hypotension. I will probably order the other tests, see the TLC which is rising, CRP which is rising. But because there's a hypertension, I will probably give the fluids are already started norepinephrine. Where the dictum of infection is source control and IV antibiotics. The old concept that you wait for 6 weeks after cholecystitis, some surgeons, some gastroenterologists don't follow it. So now it's early surgery helps in probably decreasing the complications. I may be wrong in that, but recently we reviewed it and they say that there is definite there is some data coming about early surgery also. So my best bet would probably, if the TLC is rising, there's new onset hypertension which is not responding to fluids, I will probably go to IV meropenem which is more concentrated around the gallbladder, and then consider surgery. Call the surgeons, try to them come into picture, and probably I would option A would be because the antibiotics you've not mentioned what she's on.
She was initially on ceftriaxone.
So adding doxy, probably it's not a tropical illness. So doxy is classically for tropical illness. Doxy as a whole is not good for abdominal infections. Meropenem would probably cover the anaerobic part also, but some anaerobes are still not covered by meropenem. So I would probably add metrogyl also, though recommendation is not there to add metrogyl with meropenem. But some anaerobic, especially the bacteroids, get covered by, some species don't get covered by meropenem. So maybe we'll add meropenem plus minus, but I will start considering surgery at this moment.
Anybody differing in the opinions?
I agree with that, because if your clinical suspicion is gangrenous cholecystitis, don't wait further. Go ahead with the surgery, because the criteria is 48 or 72 hours now. If it is localized cholecystitis, a contained perforation, or you can do a percutaneous drainage and wait for the interval cholecystectomy.
It was a tertiary care center, so went ahead with emergency laparoscopic.
But still, the question of loss of weight and appetite is bothering us.
The bug will tell us, sir. Ma'am, we'll go with it. So considering this scenario, patient was taken up for emergency laparoscopic cholecystectomy. Intraoperatively, there were thick congested gallbladder wall, multiple pigmented calculi, pus in the gallbladder. It's an empyema gallbladder, and there were adhesions in the omentum and hepatic closure. Fortunately, I was involved way before that, so we could send intraoperatively a good amount of samples. And what is the bug? We'll not explain much. Let's go into the amongst these four, which one will you put it for first? Option A, Salmonella typhi. Option B, Campylobacter. Option C, Yersinia enterocolitica. Option D, never impossible, Mycobacterium tuberculosis. So we'll go with Dr. Kavitha, ma'am. How much you will put on option A, B,
No,
C, D?
I mean, did she have any past history, like in the past, from 6 months? Like, did she have diarrhea?
No.
was she hospitalized or
No,
did she
never.
have to take any antibiotics for some reason?
No, she has not taken antibiotic apart for her travel. She had traveled to Africa. During that time, she had taken some doxycycline. Other than that, she has not taken any antibiotics.
She did not have to take any antibiotics in
No,
the past
no,
6
no,
months?
no.
And no gastroenteritis symptom ever?
No past history of GI before.
Any contact with tuberculosis in family or,
I don't
exposure?
recall it, ma'am. I don't recall, ma'am. I don't recall.
Childhood? Any
Childhood,
history?
no childhood histories of any hospitalization of illness in the childhood. ma'am.
Back pain or anything?
No, ma'am, no.
Okay. No, I will keep salmonella as one of the possibility for, like it's sometimes maybe just they have not, it is, we had patients who present with, salmonella spondylodiscitis where the initial manifestation of typhoid is not that conspicuous. So I'll definitely keep a salmonella infection in my mind, and being a tropical country and TB being so endemic, I will keep a rare possibility just because of the loss of weight and loss of appetite what the patient had, because this is definitely not a complete picture. And I'm not very sure about the Campylobacter and Yersinia enterocolitica. I have not seen gallbladder, patients' cholecystitis coming with this infection. So I will consider with salmonella and Mycobacterium tuberculosis.
All of you go with the same diagnosis, ma'am? Differentials.
As you said that culture was sent, on which day culture was positive?
We'll come into that, sir. The culture
That is
was
most important part to suspect the organism.
I will give it to you. Within 36 hours, cultures had been positive. 36 hours.
So the chances of microbial tuberculosis would be the very, very less.
Yes.
Then, as ma'am said, it could be typhi. And if you have put B and C option, there could be one from B or C.
Well, the word omentum rings in the ears for tuberculosis. You said there were adhesions over the omentum. Though the history is too short. If tuberculosis comes, it will be a surprise. Yes, salmonella is there, but again, salmonella for 1 month, the complication. If that history again is significant, salmonella will not cause only weight loss, loss of weight, and loss of appetite. It will come with fever, and if it is 1 month, we'll have untreated salmonella will all complications. So salmonella probably would be down. So salmonella cholecystitis is a very rare. It may occur, but tuberculosis, I always say tuberculosis can cause everything except pregnancy. So tuberculosis is a possibility. I will not put my bets on B and C, but tuberculosis, because you said there was some adhesions around the omentum and there was loss of appetite. So I would probably want to ask what was the sexual history. She has been traveling a lot. She's a young female. So what was that history? What is the history of contact and this?
No, there is nothing significant, sir. So the tissue was sent for histopathology. It just told acute inflammation. Meantime, blood culture sent from 2 different sites grew Salmonella typhi, which was sensitive to ceftriaxone, azithromycin, cotrem. I agree with that point. We had escalated to meropenem, but once the source control is done and we once know there is a Salmonella typhi with the DST, we had de-escalated the antibiotics. And the take home is we'll have to look at common things first. As ma'am really pointed out, Salmonella typhi is our differential. Patient was better post-operatively, well-controlled sugars, and histopathology, as I told, it showed transmural necrosis, subacute inflammation. There were no significant granulomas. We'll go with the second case because this will take a lot of time. It's a 53-year-old male. He's a tile worker. He's from Kasaragod, which is a neighboring district to Mangalore. He's diabetic since 10 years. He presented with fever of 1 month. Okay, 2 spikes per day associated with chills. He had loss of appetite. He had loss of weight. He had lost 10 kgs weight in a span of 3 months. Okay, abdominal pain for around 10 days. And when he came to the casualty of this tertiary care hospital, his heart rate was 120, his BP was 80/60 on 6 ml NORAD, respiratory rate was 24, SpO2 94, already on NIV. Per abdomen wise, he had splenomegaly, chest was clear. So at this point, syndromically, we have a case of a chronic fever because duration is around 1 month with significant weight loss, abdominal pain, splenomegaly, in respiratory failure, in shock. So definitely this patient is in sepsis. And these were the investigations. WBC count of 10,000, neutrophils of 84, platelet was 1,30,000, ESR was 110, CRP was 200, urea of 80 and creatinine of 2.1. So he has acute kidney injury, he has thrombocytopenia, he has ARDS, he is shocky. So severe sepsis, we can't go, I don't think this question need to be asked, patient is in sepsis. Ultrasound was done, okay, it was already done in the portable ultrasound at the casualty, which showed multiple splenic abscesses, 10 into 15 mm, and there were no vegetation according to transthoracic echo. So at this junction, before we go for a microbiological diagnosis, what will be your antibiotic of choice again? In this case, he is a diabetic, he has presented with chronic fever in shock, sepsis and multi-organ dysfunction. Option A, Mero. Option B, Mero with Clinda. Option C, Mero with teicoplanin. Option D, a high dose of meropenem. Dr. Deepak, sir?
I think, sir, you have given very good history and diagnosis almost toward the Burkholderia pseudomyeli would be at the top with the splenic abscess and uncontrolled diabetes and sepsis and ARDS. But if we are going to the intra-abdominal infection, most common cause is GNB, and most of the GNBs are now the ceftriaxone resistance. So when there's a case of intra-abdominal infection came, I would like to give either peptide or meropenem based on the clinical condition. If patient in sepsis, definitely I would like to give only meropenem to this patient.
Do anyone of you want to add a gram-positive cover in this junction, or we will, considering the clinical history, risk factors, we'll limit it?
If the patient is in hypertension, sepsis, I would probably give a higher dose of meropenem.
Okay.
Not the conventional dose of 2 gram. I would probably consider it. He's a diabetic. So you said there are two choices, meropenem conventional and meropenem 2 grams.
2 grams.
I would probably go for the 2 gram dose because the patient is sepsis and in hypertension.
Okay. So this patient, blood cultures were sent before starting antibiotics. Only one problem is he has exposed to antibiotic. I'll give you the history. He has been roaming around hospitals for around 3 weeks. He has received moxiflox for 5 days. He has received amoxiclav for 5 days and ferropenem for 10 days. These are his antibiotic history before landing up here. And blood cultures, 4 bottles, each bottle 10 ml blood were sent, and it is sterile. At this scenario, what will be your clinical call? Is it continuing just antibiotic, or patient is shocky? Will you ask an intervention radiologist or gastro to aspirate? Is it really a pus, or is it something else? Those lesions are in the splenic lesion, would you like to characterize? Or directly get a biopsy? Option last D is splenectomy. The source is spleen, remove the spleen. So how many of you will go with option A, continue IV antibiotics? Because patient is in shock. It's not a...
I think so. I'll probably go for more investigations. I would like to get some repeat after about at least 48 hours, the hemogram, the CRP, Procal, a repeat imaging. If the patient is stabilized, I would probably like to get a CT, look for abscesses. How large are these splenic abscesses? There are multiple small abscesses, because sometimes it's very difficult to differentiate splenic infarcts from splenic abscesses. So that differentiation, it could be infected infarcts, it could be multiple splenic abscesses. If single splenic abscess, multiple splenic abscesses, they are basically emboli. If the last splenic abscesses, they are primary infection, the primary splenic infection. So diabetic with splenic abscesses, I would like to probably get an imaging. I would probably continue the antibiotic. Going ahead with an emergency splenectomy, going in for an intervention, I need to know the size of those before I plan some intervention.
What about his chest X-ray?
Chest X-ray was normal.
Okay, and also I would adjust the dose of the antibiotic because he has got a
Renal failure.
But would continue the antibiotics at this stage and ask for maybe CT scan. CT
Yeah,
abdomen.
as Madam told, these are the three options we had: CSCT, MRI, PET. PET obviously not. We got a CT abdomen, plain. It's not a contrast. It showed a wedge-shaped, hypodense, non-calcified, non-enhancing nodule, 3.4 into 3.2 centimeter at mid-pole, subcapsular region. There were few retroperitoneal node. To be sure, this is not a chest plain abdomen, and it was done in a hurry because patient was in shock, could not be shifted much, and whenever we are shifting him, his inotropic requirements used to go up. So not a completely stable patient. This was the CT report. We got, once he's slightly stable, we got a PET CT done for this patient, which showed diffuse low-grade metabolic activity noted in the spleen. It was, SUV was around 7. Low-grade metabolic activity with cystic lesions in the peripheral aspect, the inferior pole of spleen, adjacent to the paracolic region. Multiple non-FDG avid hypotense lesion with the spleen and some metabolic activity in the lung nodules. And there was hypermetabolism in the bone marrow as well. There were no uptake in the spine, and there were no uptake in the liver as well. Even the lung, the uptake, the metabolic activity was very faint, not very significant. At this point, now we have a CT, we have a PET. So what do we do next? Shall we go ahead with splenic aspiration or a biopsy? Option B, ball. Option C, bone marrow. Option D, all of the above.
If your radiologist is willing to do splenic pus aspiration,
Okay,
that will be the first.
first thing. Anybody differing on that?
You are telling is cyst, not the abscess.
They are characterizing it as cyst, but the radiologist was very sure because contrast was not given. So he told we may get more information with contrast.
But PET also doesn't show any major.
They have told infective. They have told infective predominantly.
Maybe for me, bone marrow may be the better option rather
Bone
than.
marrow.
Yes, the easiest investigation for the physician is bone marrow,
Bone
because
marrow.
in BAL we have to consult pulmo, and splenic we have to go to IR. Bone marrow can be done immediately.
We had a IR, fortunately.
But the yield from marrow for infections is, if you're thinking what is your pretest probability before you do a marrow? If you're thinking of malignancy, because infective cultures is going to take time. So again, splenic aspiration biopsy, you say the patient is very unstable. So I would again probably ask the radiologist that PET people to sit together, review the CT scans and the PET scans, because you said you can't do a contrast, but you could do a PET and a CT simultaneously.
No, this was once the patient is relatively stable, we took for a PET, but not on inotropes. During the PET CT shifting, the patient was not on inotropes, not on oxygen. So this may be not on the same day, sir. This may be around 5 days later.
Again, it is very difficult to differentiate. It's a wedge-shaped, peripheral-based opacity, nodular opacity in the spleen. It may be infected infarct, or it may be an abscess. So, did you get a tissue diagnosis? I would probably get with a splenic aspiration and a biopsy rather than a marrow at this moment. Yield would be from that.
I would also send, if you have a facility, lateral flow assay for miliardosis from urine, you know. Urine. That is something which is useful for disseminated miliardosis. And patient is in shock. So some of these non-invasive tests is something I would like to explore.
So this patient, we had a friendly IR who came immediately, and we could get a aspirate. Gram stain showed plenty of pus cells. Pus was sent in blood culture bottle. Okay, we sent, and it was not growing anything. We waited for around 5 days, nothing. Gene expert TB ultra was sent, which was negative. AFB smear negative, and MGAT is not the first one. Like 4 weeks follow up, it came negative. We also got a biopsy from one of those lesions, and it showed granulomatous inflammation. And I had to discuss with the pathologist, and they did AFB stain, PAS, and GMS. All were negative. What is the bug? Option A, our clinical differential is still pseudomyeli, Burkholderia pseudomyeli. Option B, tuberculosis. Option C, lymphoma. Option D, none of the above. You are free to put your differentials, if any.
What was the result of bone marrow?
We'll get back to, sir. We have done bone marrow also, but not on the day. We got it a little later. I can tell you it was reactive. There is nothing. Bone marrow cultures were negative, and histopathology and aspirate were just telling reactive. Nothing conclusive in bone marrow. Blood cultures are negative. 5 days over. 4 bottles, blood cultures, pus sent, everything is negative.
Is this patient, does he have a travel history? Is he a permanent resident of Kasargod? Any travel from, like, is he a migrant person?
No. He is a tile worker. I will give you his history. There is a lot of things. He is a chronic ethanolic, drinks the local toddy every day. And for some festival purposes, he used to walk barefoot also. Other than that, he is completely a localite of Kasargod. Never traveled apart from Kasargod, Kannur and Mangalore. These are the 3 districts he has traveled. He has not gone anywhere else.
Of these 3, lymphoma will not cause renal failure. If it is renal failure is because of diabetes. The only differential I can think of a hematologic malignancy which can cause, which is very unlikely, is the multiple myeloma, because diabetic renal failure, you have to keep myeloma, but this is not the condition, it could be disposing condition. Tuberculosis, you have an MJ, everything is negative. Granulomatous inflammation is not synonymous, though everybody says it. So my bet still would be on Burkholderia A of all these 3. So that would be my bet, because the patient has, is the patient's shock is recovered?
Shock is recovered, but he is persistently febrile. His fever is 103.
Possibility would still be, lymphoma will not present like this. Lymphoma will not present with multiple splenic lesions. Lymphoma will present with lymph nodes elsewhere also. Only intravascular lymphomas can present with splenomegaly and small lymph nodes. Intravascular lymphomas are known entities which can present, but again, they will present with splenomegaly, not splenic S1s.
How old is the person?
He is
Like above 40 years?
yeah, he's 53.
Yeah, 53.
53.
So basically, he's 53 means he's a risk factor, and he's got multiple risk factors like alcoholism, uncontrolled diabetes. And Kasargod is quite endemic. So all of us, I think, we are, hitting on Burkholderia pseudomyeliae. And patient is improving on meropenem, isn't it?
His hemodynamics is improving, but his fever has not defervesced at all.
Yeah, so obviously, I mean, it takes time for even if it is Burkholderia, even if your diagnosis is right, it takes time for the fever to respond. And we know it's like median time for defervescence is around 9 days in pseudomyeliae. So I would just continue that meropenem, dose adjusted.
You will give 2 gram, ma'am, or 1 gram?
No, I would give, for the normal person, 1 gram 8th hourly would be the dose, unless he's in altered sensorium or something like that. If I'm thinking of
prolonged infusion or intermittent
prolonged infusion, I would give prolonged infusion, dose modified for renal failure.
And no ID, CME or conference can be without Burkholderia. So seeing the statistics, the Burkholderia seems to be more likely than.
So this was one of the times when.
This is the time usually our microbial is alert. We still didn't get any.
No. I will come there. There's a little more spice in it, sir. So this was one of the time when I think KMC Manipal started doing Burkholderia pseudomyeliae PCR, and fortunately it was on a research project. So we sent from Mangalore to Manipal pus for pseudomyeliae PCR, and that is negative. Bone marrow aspirate, histopathology, all are negative. So what do? He is on a 3rd week of marrow. Okay, now the story is on 3rd week, still febrile. 2 attenders, one is a chartered accountant, and he is having a lot of questions. First question he asked me is, do you have a microbiological diagnosis? The exact same word he had asked me, doctor, I can see you giving meropenem. Do you have a microbiological diagnosis? At this point, I didn't have an answer. So what do? Surgeon, this is admitted under surgeon. Let's be very clear, it's not admitted under me. So he's very keen on option A, splenectomy. Option B, empiric ATT. He's also keen on that because fever is not settled. He's worried about it. Option C, switch to ceftazidime. Now he is not in sepsis. He's not in shock. He's not having, other than fever, he's not even in respiratory failure. Option D, BAL. There was some uptake in the lungs, but very faint. There are a few nodules. Shall we go ahead with BAL? So will not, because of the time constraint, will not go into explanation. How many of you feel will go ahead with option A? None of you. Option A. Okay. Anybody in option A in the audience? Nobody. Option B, empiric ATT. Okay. Option C, switch to ceftazidime. Anybody off the point? Okay. Option D, bronchoscopy and BAL. BAS. Yeah. BAL is done. So there is a gram stain is showing gram-negative bacilli. Again, cytology is neutrophilic, no atypical cells. Gene expert ultra is negative. MJET after 4 weeks. I'm not telling within a week or within 2 days. MJET on follow-up, it has been negative. We even send for fungal cultures. It is negative. Only thing in the gram stain, you have some information that there is a gram-negative bacilli in the smear. He is still febrile. Again, the surgeon is very keen. Shall I go ahead with splenectomy? So what do we do? We come into 3 options now. Option A
repeat
is
imaging, repeat CT. 3
You
weeks.
should get the identification, no, isn't it? BAL, you have got gram-negative bacilli.
In the smear, ma'am. Culture didn't grow.
Oh, it didn't grow.
It's only in the gram stain. There, a microbiologist could visualize a gram-negative bacilli.
And what are the spikes like? What is the temperature? How much is it?
He is spiking between 102 to 101 every day, 2 to 3 spikes. But it was a continuous fever. It has reduced now.
So what are the other parameters? The TLC, the CRP,
Yes, sir.
the Procal, the imaging. What are the other parameters in this patient?
Total count was 9,000.
So it has decreased to from 17,000 to 9,000.
9,000. And C-reactive protein from 200 had come to 150. Creatinine was normal. We had not done Procal.
And repeat imaging?
Repeat imaging showed just the same lesions. Ultrasound, we have not repeated a CT. It was showing the same multiple splenic lesions. And this time radiologist was very clear, it is splenic abscess. Looks more, because he compared, the same radiologist got the USG last time.
We had a similar patient, went ahead with the splenectomy and we found the diagnosis.
That's nice, but for this patient, I actually took a clinical call of shifting to ceftazidime, 2 gram 4 times daily. He had a fever defervescence after 7 days. I don't know whether it is post-meropenem or post-ceftazidime. It's very difficult to extrapolate. And the CRP came down from 150 to 60. Once fever defervescence is attained, attenders were comfortable and we continued for 2 weeks. And suddenly we have a magic here. Suddenly he developed right knee swelling and it was tender, restriction of movement. Only thing, he was complaining of pain. It's kept on increasing. And no fever. On attempting, so we got a synovial tap to see whether it is a septic arthritis. That was a frank pus which was oozing, and pus was told by orthopedists to send for the investigation. At this point, what all you will send? We have a pus from the right knee. What are the tests you will ask for apart from the synovial routine analysis? Option A, gram stain and culture. Option B, gene expert. Option C, A plus B. Option D, all of the above, and inoculate maybe in pediatric blood culture bottle. How many of you will go with option A?
So just I missed probably. Was there any MRI of the knee joint done?
No, we did not.
Because that would also help little bit.
Yes, could have done that.
Joint muscle involvement is quite characteristic in Burkhold area. So that I would like to use that opportunity to see if there is muscle abscess, intramuscular abscesses that favors, because here joint involvement would be also associated with intramuscular abscesses. That would have
added
made
more.
It more. You could have identified a little bit. So, and also the biopsy from that tissue, that would also be a better
histopathology,
better specimen to give the diagnosis.
We had some cost constraints for getting MRI at that point because they had spent a lot of time on this. So fortunately we could inoculate along with the routine test. We could inoculate in pediatric blood culture bottle. Why pediatric blood culture bottle? It dates back to 2001. These results indicate that when in these kind of scenarios, inoculating in pediatric blood culture bottle may increase the yield of the organism, and fortunately we have a diagnosis, as all of you have rightly suspected. It was Burkholderia pseudomallei. It was pan sensitive. And what will be the duration of therapy? IV 6 weeks. You'll go with IV 6 weeks of ceftazidime followed by 3 months of eradication therapy with Cotrim. In this case, option B, source control plus 1 month. Option C, 6 weeks followed by 6 months of cotrimoxazole. Option D, none of the above. Anyway, we'll go between A, B and C.
Yeah, so basically patient has splenic abscess.
Yes, splenic and septic arthritis.
Also, I mean, other places there may be abscesses. That is something like male patient, right?
Male patient,
so
yes.
prostatic abscess is another place where we should look for, at least ask for the symptoms. The recommendations is about 6 weeks, IV antibiotics for 6 weeks. But I really don't think every patient requires 6 weeks of parenteral antibiotics. So if you have constraints, patient is not willing, and it's difficult to give 6 weeks for every patient. So even I would go source control as much as possible. For the knee, definitely we have to do the source control. If the patient becomes afebrile and the spleen lesions are regressing, then we may get away without splenectomy. But definitely I will give 4 weeks of IV antibiotic, and the good long period of eradication therapy is important. That is something which we should not compromise on. So if I cut short to the 4 weeks of parenteral therapy, I will go for 6 months of eradication therapy with cotrimoxazole. In this patient, I hope that his creatinine would have improved, normalized. So then I will go for the full dose of cotrimoxazole. Means I wouldn't go for a 6 weeks of IV antibiotic. I would probably go for a 4 weeks of IV antibiotic. At the same time, I will re-image the patient and see how are the spleen, how is the knee joint after treatment of this end of intensive phase.
So in this case, there were no prostatic symptoms. Ultrasound and truss was done, transrectal ultrasound was done. There were no prostatic abscesses. We went ahead with synovectomy, arthroscopic guided debridement of the joint, and we had cost constraints to repeatedly investigate. So we gave 6 weeks of IV. He was discharged, went home, and oral Cotrim for 6 months. We could repeat a CT when he came for follow-up on 6 months, and there are all healed lesions, no nodes at all. And when he came, he brought the whole family with him with a weight gain of 10 kg. So clinically, I felt he improved, and he's still on a close follow-up with me. So sometimes we still have to put our foot telling clinical diagnosis matters. All the panelists were very firm that it is Burkholderia pseudomale, and in a due time we got the diagnosis. He didn't require splenectomy, by the way. Burkholderia pseudomale per se, it's a gram-negative environmental bacteria, and it's an etiological agent. Why diabetes? It is even more fascinating. It has blunted pseudomale cellular response, especially during acute infection, and decreased capacity of macrophages to phagocyte. This is a review guidelines by Darwin. I'll not go into detail. According to this, if you have an osteomyelitis or a deep-seated collection, you can treat from 4 to 6 weeks, especially for osteomyelitis 6 weeks, followed by eradication therapy for 6 months. As far as I remember, this is the most recent guidelines we have, 2020.
So, I mean, we have a lot of evidence for any osteomyelitis that oral antibiotics is also non-inferior to IV antibiotics. So, these guidelines were all made much earlier. To this. And so, we can also consider oral antibiotics a little earlier. But definitely, a minimum of 2 weeks of parenteral antibiotic is required for melioidosis. But beyond that, we can adjust according to the clinical impression. Even for neurological melioidosis, I personally do not think that 8 weeks of IV antibiotic is a must in all cases. So there's a scope, and there's a good scope to do RCTs.
Do we have time? But I'll have one more case then. Do we have time? Okay, I'll go with the last case. I'll make it very quick. As we have two legends from north and west, I thought we'll bring some case from east. So 33-year-old male from Bangladesh, he's a restaurant businessman. He presented with right upper abdominal pain for 4 months, severe abdominal pain, intermittently coming, and it lasts for around 5 months. It relieves on its own, according to his explanation. He had sweating, on and off sweating, some low backache, and weight loss of around 11 kgs in 3 months, and no fever, vomiting, loose stools. These are cases which are seen in OPD, so we may not be able to work up fully. They have come and gone. Review of system were normal, no recent travel, no animal exposure, no raw milk consumption. He's a non-vegetarian. He consumes beef, mutton, chicken, no raw meat. He had COVID in Jan 2022 and alcohol consumption for around 10 years, around 360 ml of whiskey. He has tried inhalational drugs also and weekly tries. 2 years ago, he was admitted for alcohol poisoning also. He had PTB 2006, took ATT for 6 months and was evaluated in Bangladesh. CACT abdomen report, this is an outside report, showed multifocal cystic mass-like lesion in right lobe of the liver with minimal enhancement. HPCG, HCV and HIV were negative. Ultrasound, again outside report, showed multiple hepatic space occupying like lesion like multifocal abscesses which are reduced in size compared to the previous scan. UGScopy was done, which was normal. ESR was 41. Total count was 9,200 and this was of outside reports. These are our reports. Hemoglobin of 15, total count 6,000, neutrophils of 30, monocytes of 4 and eosinophils of 10 with a GGT of 98 and ALP of 131. Eosinophils double differential counts was checked again and the absolute eosinophil count maybe after 2 days later it was around 1,600 absolute eosinophil count. And these were the ultrasound abdomen. It showed multiple ill-defined circumscribed mixed echoic lesion in segment 8, segment 4A and 4B. What are our differentials? Option A, we can have another case of pseudomyelite, that's not a story. Option B, tuberculosis. He is from eastern part of India. Let's keep the dimorphic fungi also in the picture. Histoplasmosis, cryptococcosis. We need more details. You need more details? Yeah, we'll go with the details. So diet history we revisited. He consumes veg and non-veg salads, including raw carrots, ladyfinger, spinach, carrot, broccoli, tomato, capsicum, everything raw for reasons unknown.
One of the things is echinococcus also he has to think of it. Hydrated also.
Okay. Anything else?
Well, if you see the history, he is a person from Eastern India. He has he has liver SOLs. His alkaline phosphatase is near normal, so there is no infiltration. So you can't have he doesn't have a neutrophilic response. So pathogenic infections are out because the neutrophil count is 30%, TLC 7,000. So pathogenic liver abscess is out. He has an eosinophil count of 10%, DLC. So parasitic infections, he has a history of eating exotic foods. So parasitic infections can't be ruled out. So I would like to know the imaging, especially the MRCP. Are there any?
I think there was eosinophilia, isn't it?
Yes.
So, the tissue flux is something which we should consider because the eosinophilia is present during the invasion when these flux enter into the unusual paths. So, fasciola, clonarchis.
But ma'am, actually, whenever they enter into the paths, they are always associated with inflammatory findings, ma'am. So they will have some CRP rise and there is some neutrophilic response. So there's eosinophilia, but there is no neutrophilic response. There are no signs of inflammation.
Here 10% eosinophils.
Yes, 10%. 10% and absolute eosinophil count 1,600 when they rechecked it again.
Yes. So parasitic infections would be probably hydrated would not cause this type of lesions on CT probably.
So this was multiple grape-like cluster type cystic lesions in liver with some periportal nodes. I will go into as the constraints of time will not talk much. Went ahead with ERCP, bile samples were sent. They couldn't visualize any worm, but there were multiple grape-like hepatic SOLs with peripheral eosinophilia and a chronic alcoholic, bile culture negative. We thought of hepatic fasciolasis in this case. Yes, so we thought of clinico-radiologically because we didn't have any antibodies to check or ELISA to check at that point. We suspected hepatic fasciolasis in this patient. We didn't have the ideal drug of choice. Ideally, we need to give triclobenzo, but we didn't have that. So we give nitazoxanide, 500 mg TID for 4 weeks. 3 months later, because this is a patient from Bangladesh, 3 months later the patient came for follow-up, and clinical and radiological improvement is there. Credits to my colleague at that point, Dr. Naveen. He had seen this case and he had followed up this case at that point. So this is triclobenzol is the current drug, but when it is not available, think of nitazoxanide. These are the case series from Apollo about human fasciolasis diagnosis by CT and clinico-radiologically. In this 16 cases, 7 were male, 9 were female. All patients habitually consumed raw vegetables and leafy greens, and all of them had pain in the right hypochondrium. 31% reported weight loss, and these are the radiological features. In this, one of the thing is fasciola cluster of the grape sign and a linear tract sign. Okay, linear tract sign. So this is fasciola clusters and fasciola tunnel sign, which are very typical radiologically. I don't think we have time, right? One short case or I thank the team for giving me this opportunity. We had another 2 cases, but if we had time, we would have continued it. Okay. So summary, cultures are paramount. Always put your clinical diagnosis in mind. For example, in the second case, we kept talking about pseudomyeli, and in a matter of time, we could prove the pseudomyeli. So sometimes your clinical diagnosis matters a lot, and suspect your clinical. For example, if you suspected TB or maybe crypto or histo, you may suspect it, but try to prove it as well. And always discuss with your friendly microbiologist and infectious disease consultants. And if you have them on board, you can solve many mysteries like this. So increasingly, the world around us is focused less on individual achievements. It's more of collaboration between all of us. Thank you. Any queries? Anything?
Any questions?
Usually ERCPOS, you can extract that.
Wow. Yes. No, they at that point we didn't find it. They couldn't extract it.
And it is said that they have a party there. They are dancing. So I try to find the video. Those parasites, they come in numbers. They are there, and there are 2 phases of that illness. The first part has eosinophilia. In the second part, there is no eosinophilia. Once they are there, they've resided there, it is inflammation. They present with micro-abscesses. Eosinophilia is absent. That actually, so there are 2 phases of that illness.
Yes. Do you do antibodies, sir? Then, like, do you have any diagnostics where you can send ELISA or
we have a PCR there. My parasitology does it, but that was negative. It is negative in the second phase. If it is positive, only in the first phase.
You have fasciola PCR there?
Yes.
Okay. Okay. Thank you for the opportunity.
Thank you, sir, for the panel discussion. Now I invite Dr. Muralidhar Verma to kindly present memento to Dr. Ganesh Bhat, to Dr. Kavitha Saravu and Dr. V.K. Vineeth. Thank you, sir. Now we'll move on to the next session. To introduce our speaker, I now invite Dr. Kavitha Saravu to present the profile of the speakers.
we have arrived at the much anticipated session and segment of this IDA update. And this is a pro-con debate. In our routine clinical practice, we encounter a common scenario of recurrent urinary tract infection. And we are at crossroads, clinical crossroads sometimes, because we want to give relief to our patients and long-term symptom-free comfort to the patients. And we are also concerned about the antimicrobial resistance in the same patient or even in our practice. So the debate now is to give antimicrobial prophylaxis for recurrent urinary tract infection, yes or no. To give a point of view of yes perspective, we have Dr. Akshatha Ravindra, and to give a counter perspective, we have Divya Joshi. So Dr. Akshatha is infectious disease consultant and infection control officer at Kaveri Hospital, Bangalore. And at her young age, she has so many credentials, and she is an international ambassador, India ambassador for ECMID, and she has already contributed to many guidelines, international guidelines for ECMID, wiki guidelines, even that is on urinary tract infections, transplant infections. So many accolades to her credit. And Dr. Divya Joshi is a consultant infectious disease at KIMS Hospital, Bangalore, and her interest are a lot of gram-negative infections, antimicrobial resistance. So I am very excited and look forward to this exciting session. And I call upon Dr. Akshatha to present the yes perspective for antibiotic prophylaxis.
Okay. Good afternoon, everyone. At the outset, I would like to thank, and it's always a pleasure to be back to KMC Manipal. Thank you, Dr. Kavitha Muralidhar, sir, for having me here. And I hope I'm not stereotyped into only having debates. So let's start with it. So I'm here to talk about, is long-term prophylactic antibiotics justified in recurrent UTI? Yes. So we'll start with the case. So I have a case with a 32-year-old teacher who has 7 culture-proven UTI in past 1 year. She has received 9 therapeutic antibiotic courses in the time, and all this time there is anxiety that she may develop UTI again. There is questions regarding whether she intimacy and travel. So by the show of hands, can I have, how many of you are confidently thinking that she should endure the next episode and not start or any prophylaxis? Anyone confident enough? So she was advised to start post-coital nitrofurantoin, after which her breakthrough UTIs reduced dramatically. There was no hospitalization over the next few months, next 1 year, and she returned to normal functioning. In the meanwhile, she was advised the non-antibiotic behavioral changes. She was advised even cranberry tablets, all of which could not avoid her current situation. So when we talk about recurrent UTI, we are not just dealing with the infection perspective. This is a spiral basically. There is acute infection, after which there can be a temporary cure. You give antibiotics, treat the infection. And once the patient starts having this multiple times, there is a development of anxiety, there's missed work, there's avoidance of traveling, intimacy, concerns regarding getting infection from use of public toilets, etc. So when invariably the reinfection happens, there will be repeated ER visits, progressing to, so now we all know a lot of ESBL. So whenever you're thinking, even if you want to start empirically, the patient may be started on what? Carbapenem. So this cycle will not stop if we do not consider prophylaxis. So next case, I have a 64-year-old diabetic woman with 4 febrile UTIs in 8 months. She had 2 admissions for pyelonephritis. ESBL UTI, E. coli was there. So That's where the prophylaxis is important. So when the patient is getting admitted for UTI, you are going to give full therapeutic course, which will again add to the AMR pressure, and each hospitalization there may be a patient will be subjected to broader antibiotics. Instead, if we give the targeted prophylaxis, it may reduce the overall exposures. Third case, a typical example where most of the times that is a neurogenic bladder, a spinal injury patient on intermittent catheters. He has monthly symptomatic UTIs. All the admissions will interrupt their rehabilitation. Instead of considering the treatment of the UTI, we should get on how we can prevent them so that the patient is not subjected to the infection as well, and also that so that his rehabilitation continues. So the question here is not whether everyone needs a prophylaxis. The question is whether the selected patients will benefit enough to justify it. So the answer is precision and not prohibition. So again, most of the times the recurrent UTI itself is misdiagnosed, I can say. So the definition is more than 2 UTIs in 6 months and more than equal to 3 UTIs in 12 months. UTI does not mean culture positivity. So many times cultures may be, the patient may be asymptomatic and the cultures may keep growing. And if you consider treating those, then you're wrong. So definitely the definition wise culture needs to be confirmed, but it must be accompanied by clinical symptoms, and also you need to differentiate between the reinfection and unresolved relapse. So is there evidence? Definitely there is a lot of evidence. There are a lot of RCTs which is done with the antibiotics used in preventing recurrent UTI. Most of these studies, one which includes continuous low dose antibiotic prophylaxis versus placebo, where there was around 64% reduction. Then there is also studies on postcoital antibiotics with versus the daily ciprofloxacin, where the risk of UTI significantly reduced. Placebo-controlled evidence-based trials also indicate 85% lower risk. There is also a systematic review and meta-analysis which shows that the antibiotics reduces the recurrence by 24%, and numbers needed to treat was 8.5. And there is a retrospective cohort of around 20,000 adults where they have compared even the male versus the female UTI, and they have found that this prophylaxis is associated with lower recurrence, lower acute antibiotic prescribing, and lower UTI related hospitalization. And what do the guidelines say? They do not discard the prophylaxis or use of antibiotics. So nowadays the guidelines are moving towards use of non-antibiotic alternatives, definitely, but they do not prohibit the use of antibiotic prophylaxis. So what do the ICMR say? The ICMR in uncomplicated recurrent UTI recommend post-coital antibiotic prophylaxis where appropriate, low-dose nitrofurantoin, single-strength Cotrim, and alternatives which is Cipro and Cephalexin, which may not work in Indian context because we do have a lot of ESBLs, and definitely not fluoroquinolones because we have high rate of fluoroquinolone resistance. Next, I am sure this is one of the things which may be brought up by my opponent. So the resistance paradox. It's not that prophylaxis always drives the resistance. In reality, if the patient is subjected to repeated 7-day full course of therapeutic broad spectrum agent, this will add to more broader resistance than the prophylaxis itself. And the collateral microbiome disruption is much less with nitrofurantoin or fosfomycin, which exerts minimal collateral impact. Definitely this is possible with fluoroquinolones, and like I said, I do not recommend use of fluoroquinolone in Indian context. So what about non-antibiotic prophylaxis? So this is an endless list of the non-antibiotic prophylaxis, which is recommended also by few of the guidelines. Cranberry products, D-mannose, vaginal estrogen, methenamine hippurate, and others, probiotics, etc. So what are the limitations with this? Cranberry products, so this is based on the wiki guidelines. So cranberry products, they do recommend, there's a clear recommendation in selected population, but what are the concerns? So it is restricted only to a set of population with uncomplicated, which is uncomplicated. There is insufficient data in elderly, in neurogenic bladder, in pregnancy, bladder dysfunction, and severe recurrent diseases, which is the most common scenario in our setting. Next, again, the vaginal estrogen, definitely it is, there is a clear recommendation and definitely it will benefit, but this is mostly restricted to only post-menopausal women, and also it has delayed onset of action. What would you do in the interim period? Next, the D-mannose, there is no sufficient quality evidence to give clear indication. There has been discordant or uncertain results among the prospective studies, and also with smaller sample size and differing dosing. And I am sure my opponent will bring about the recent trial on methenamine hippurate. This methenamine hippurate requires functional bladder and urinary acidification, so no in case of neurogenic, as well as there have been the study itself showed that there was increase in infections, that is breakthrough infection, once the prophylaxis is discontinued. So I would place them in this manner. So use of cranberry, there is low quality, high mixed evidence, whereas with vaginal estrogen, definitely there is high clinical efficacy and good data, but restricted to post-menopausal patients, and definitely methenamine hippurate is a good alternative, but you will also have to be careful that it was not studied on all the subpopulations, and also you should be aware of that increased risk of UTI. So would you like to choose an inferior option to do a broader good? So I would say the answer is smart prophylaxis. So where you use short duration, do not give a longer prescription of 1 year upfront. It has to be, you have to select the population and give short courses and always review it after that. Use drugs with minimal collateral damage like your nitrofurantoin or fosfomycin. And which is aligned to, that is based on the prior cultures and the local antibiogram, reviewed regularly, and definitely whenever possible you can have trigger-based prophylaxis, that is postcoital prophylaxis preferred over the continuous prophylaxis wherever applicable. So good stewardship is smart prophylaxis and no prophylaxis, and not no prophylaxis. So this is a pathway I would say. I am sure both of us would definitely at least agree later. So confirm recurrent UTI. First, definitely we have to optimize the behavior and where appropriate vaginal estrogen, and if possible look for an alternative, and try to identify the triggers. If there is trigger like postcoital antibiotics, if no triggers, you can give a trial of low dose antibiotics or methenamine where appropriate. So I rest my case here. So long-term antibiotic prophylaxis in recurrent UTI is definitely not for everyone, but absolutely justified in select patients. And again, you should remember recurrent UTI, for you it may just be an infection, but in the patient's perspective, there is a lot of psychological and mental stress associated with it. So smart prophylaxis over chaotic repeated treatment is the one way forward. And evidence and guidelines also do support UTI prophylaxis to prevent recurrence in selected population. Non-antibiotic measures is valuable, but a very restricted few population. It's not universally effective, and there is also evidence to indicate that they can be may not be very effective in severe recurrent disease, as well as in they can be associated with relapse or reinfection once it is stopped. So thank you.
Thank you, Akshatha, for that perspective. I invite Dr. Divya for the counter perspective on no to continuous antibiotic prophylaxis in recurrent UTI.
Good afternoon, everyone. I was about to remove the Dr. V.K. Vineeth's slide. I'm sorry. Thank you for removing that. Yeah. So I'm Dr. Divya, and I'm going to be talking about long-term antibiotic prophylaxis in recurrent UTI, justified or not. So prevention or resistant subscription is what I'm looking at, and my position is not justified as a routine or a default strategy. So as Dr. Akshatha had really amazing, beautiful slides, I'm sorry for this dull one. And I would like to thank Dr. Kavitha ma'am and Dr. Mulidhar Verma sir for giving me this opportunity. So the outline of my talk is going to be the newer definitions that we are all aware of. I'm going to be discussing about what is recurrent UTI and the review of literature. Talking about a little bit of expanded populations also. Non-antibiotic prophylaxis, Akshita has covered, she's done my job. And in the Indian setting, where do we actually stand? And what we can actually extrapolate to our setting. So the IDSA 2025 guidelines update we have, the older classifications have shifted to something which is quite localized, uncomplicated UTI, something which is only localized to the bladder, irrespective of the sex, and complicated urinary tract infection is something which is beyond the bladder. It includes everything from pyelonephritis, febrile, bacteremic UTI, prostatitis, etc. Even the European Association of Urology has a very similar definition of localized and systemic UTI. Understanding the syndromes. We all know asymptomatic bacteriuria. I think syndromic approach is something which we have discussed everywhere. When we're talking about asymptomatic bacteriuria, we know sure that very few situations where we end up looking into antibiotics that we give over here. Coming into the recurrent urinary tract infection. So what do you mean by recurrent? I think Akshata has pointed it out. We're looking at more than 2 culture-confirmed urinary tract infections in 6 months, or more than 3 culture-confirmed urinary tract infection in 12 months. Now, recurrent uncomplicated cystitis is not equal to all recurrent urinary tract infections. Unfortunately, whatever trials that we have done so far for antibiotic prophylaxis is there for women, especially with uncomplicated recurrent cystitis. We need trials to talk about when we are looking at upper urinary infections, pyelonephritis, men, etc. So, do recurrent urinary infections only occur in the cohort where we have actually studied? So look at the young women where you have behavioral or coital reasons, postmenopausal where you have the atrophic vaginitis. For men, we have anatomical issues and prostatic issues. Neurogenic bladder where voiding is the problem. For catheterized patients, we have these biofilm-driven and obstructive uropathy or mechanical issues. For all of these cases, do you think when one bug doesn't fit the situation, should one prophylaxis strategy be the one that should be recommended? Anyway, this is the same slide which talks about the risk factors for recurrent urinary tract infection and why was the antibiotic prophylaxis started or became popular. So it started off in 1970s and 80s when there were randomized control trials by Stam Nicole, and there was a Cochrane review in 2004 which talked about this, and with 1990s becoming the trend where continuous prophylaxis was looked into, and by 2000s where there were a few trials which Dr. Akshata showed and spoke about fluoroquinolone prophylaxis, and unfortunately we're not using fluoroquinolones in any of the treatment here, right? And now we're moving towards the stewardship era which enforces us to probably re-examine the original assumptions. Most of the evidence that we have so far are for women, almost exclusively. Uncomplicated cystitis, not for pyelonephritis. A very shorter duration of follow-up is being documented, except one trial which I'm going to discuss about it. Resistance were rare at that point of time, but now we are in the resistant era, and not just ESBLs, but also your carbapenem-resistant organisms. Recurrence was the only endpoint which was looked out in all of these trials, but the microbiome should also be looked into in these cases. So this was the Cochrane review in 2004, which looked into these antibiotics being used. So let us understand. Nitrofurantoin and Cotrim, yes, but there were resistance rates. Cephalexin, I don't think the use of cephalexin is something that we would recommend for our prophylaxis in our current age. Neither will be the fluoroquinolones, and we have one trial of it, phospho, where we had a lot of breakthrough infections and resistance risk. So what is the relevance of using these in the current AMR ecology in the Indian setting? Or when all of these studies were looked into the occurrence of urinary tract infections after stopping the prophylaxis. So when you actually ended up stopping the prophylaxis, the re-emergence of these uncomplicated cystitis or pyelonephritis was almost comparable to the arm where antibiotic prophylaxis were not used. And coming into the antimicrobial resistance, ecological and the microbiome cost. So do we actually talk about this? Coming to the same case which Dr. Akshata sort of did, and I was actually surprised why wasn't there a carbapenem resistant bacteria sitting there after having 6 to 7 episodes of urinary tract infection. So this was a 55-year-old female, post-menopausal, presented to the OPD with frequency, dysuria, urgency, but now also with fever and loin pain since the last 1 day. So there was an admission in the ICU in 2025 December with urosepsis secondary to an ESBL E. coli where meropenem was given. Unfortunately, she did receive an oral phosphomycin following that as well. No, not uncommon in our setting, isn't it? So 3 months later, she did develop cystitis secondary to an ESBL cleb and she was treated with cotrimoxazole. And 1 month later, so this is the third infection that she is suffering in the last 6 to 7 months. And we are looking at presentation in the OPD with the following complaints, and this is the culture report that we are looking at for this lady. So coming to the same question, does she warrant prophylaxis after listening to it? Yes, obviously she does, right? But what to give? Right? And this is what is the issue that we face in our current day and age. So yes, we know that probably prophylaxis are going to help, but what to give? So the context that we are prescribing into becomes very, very important. So we cannot extrapolate the data which has been done in UK, Nordic countries, US, etc. to the far left side of the curve. We're looking at South Asia and these countries where we have an ESBL and CR prevalence which is quite high. Correct. So coming to the next one, which was also discussed, the BMJ long-term antibiotic prophylaxis, which looked into systematic analysis of 3 randomized control trials where these antimicrobials were used. So it looked into nitrofurantoin, Cotrim, and nitrofurantoin, which compared to vaginal estrogen pessaries, it compared to probiotics as well as manos. So there were these 3 randomized control trials which were included, and again, as I said, mostly women with limited data on frail elderly or nursing home representations, shorter duration of follow-up, so we don't know what is actually happening after 6 months or 12 months of this thing, and where does it fit into the Indian AMR situation. Having said that, when we talk about the stewardship concerns, according to this trial, 90% of those who were there on the cotrimoxazole developed resistance within 1 month as well. So the efficacy of prophylaxis, which is established in the microbiological ecosystems, which is very different from the current setting, and a prophylaxis strategy validated in this low resistant Western ecosystems might not translate to the current ones. Correct. So this was the trial which, this is the prophylactic antibiotics to prevent recurrent urinary tract infections and risk of antibiotic resistance. So this was the latest one which was actually published in 2026 Lancet. The SAIL data bank study, this was done in Welsh population. And I was surprised to see that the primary outcome when they talked about was the hospital admission with a resistant infection was actually not increased in comparison on prophylaxis. So, but having said that, and let us read between the lines, when we looked into the resistance to more than one antibiotic on culture and multi-drug resistant organisms, the number needed to harm was actually 15 and 12.5, which actually was less when it came to frailer individuals where the number needed to harm was actually 9.7. So technically, if you end up prophylaxing your individuals or women for recurrent urinary tract infection, out of which you will definitely develop out of 1 in 9 will end up developing the microbiological cultures which are actually resistant organisms. Having said that, when they spoke about there were no increased infections, if you look at the median prophylaxis duration was only 78 days in 2026 Lancet publication, and the follow-up was only 52 weeks. So this was the major concern, and what we're looking at as a ticking time bomb. Which probably, we're colonizing our vaginal as well as rectal areas with carbapenem-resistant organisms, which is already colonized. Now, to counteract that, this was the one which was published in BMJ 2025, which spoke about exposure of suppressive antibiotic therapy in women with recurrent urinary tract infections, and what was it where the severity of infections led to. So this was this was a retrospective cohort of 36,170 women with recurrent urinary tract infections, and the follow-up was substantial. If you look at it, it was followed up for about 8 years and 4 months. And if you look into a longer follow-up duration, let us look at the pyelonephritis hospitalization, which had actually doubled. The hazards ratio was around 1.95. So on chronic prophylaxis for were more than twice likely to be hospitalized with a bad pyelonephritis later. So given this, the authors themselves said the real question is the widespread application of this long-term prophylactic antibiotics, especially the given absence of actually clear evidence data supporting their efficacy beyond the lower urinary tract infections. So having said that, the nitrofurantoin and Cotrim is not less of side effects for chronic use. So every agent that we end up using for chronic prophylaxis has some effect on the cumulative organs as well. So, and let us look into the fact, where have we actually done these prophylaxis that we have done? So, in very, very strong recommendations and RCTs are there for the pre-menopausal women with uncomplicated recurrent cystitis. Post-menopausal women definitely yes, but what about men with recurrent urinary tract infections? What about the neurogenic bladder situations? What about self-catheterization patients? What about the pregnancy and children? So, this is where we are actually focusing our cohort on, where we have actually done the prophylaxis trials. Right? Outside of this, every major guideline either restricts or probably advises against chronic prophylaxis. As I said, men with recurrent UTI, no robust evidence to support it. The neurogenic bladder, the intermittent self-catheterization patients with the ANTIC trial also spoke about reduction fairly, but the antibiotics used were also not deemed fit in the situation where we would use it. And having said that, the guidelines do not routinely offer long-term antibiotic prophylaxis, definitely for intermittent self-catheterization. Coming into long-term catheterization patients, big no. Coming into pregnancy and pediatrics, we know we screen and treat the ASBs or asymptomatic bacterias in pregnancy, but there's no long-term suppression that we recommend for pregnancy as well. Coming into the pediatric populations with the ones with vesico-ureteric reflex, which is bad, there was a trial which was done and it looked into Cotrim prophylaxis which halved the recurrence, but having said that, there were a lot of breakthrough infections which were there in the prophylactic arm. Also, given the same time, there was no reduction in the renal scarring that we looked into, what we are worried about in these situations. So I would just briefly skim through the antibiotic, non-antibiotic prophylaxis methods because it's already been discussed by Dr. Akshatha. So the ones which are a little highlighted in blue are the ones which there has been some role with vaginal estrogen. What does it do? It restores the lactobacilli and lowers the vaginal pH. The cranberry proanthocyanidins will block the attachment of these E. coli to the uroepithelium. Methenamine makes the urine acidic and hydrolyzes formaldehyde into the urine, acid urine, and it acts as a local antiseptic as well. We do not have the vaccines which have come up, but definitely hydration is a big thing to go around it. So these are the trials which looked into the non-antibiotic prophylaxis, and the ones, so I'll just skip through this fast because we already looked into this. There's a Cochrane 2023 data which looked into 50 RCTs about the cranberry tablets of 36 to 72 mg, and this was one of the ones which looked into a higher dose which was effective in reduction in the recurrent urinary tract infections. Having said that, the data is only for lower urinary tract infections and cystitis. Neither the non-antibiotic or the antibiotic prophylaxis talks about something that we are looking at, upper urinary tract infections. So this was the ALTER trial which you very nicely left for me, so I just talk about it. So this is 240 women where experimental one was the methenamine hipurate, which is 1 gram taken twice daily, and the other antibiotic prophylaxis. If you look at the intention to treat and per protocol analysis, we had antibiotic, the results which talked about the methenamine use for this was, it met the non-inferiority. Resistance emergence was definitely higher, that I've already discussed, and the side effects were also lesser in comparison to the ones where it is. So similar efficacy, but having said that, there were breakthrough infections which very rightly pointed out, and understanding these trials into when and where to use it should be important. Right, so this is the one, the ALTER one, the Cochrane one, the vaginal estrogen one, and we're looking at still if we have any vaccines. So before, do antibiotics work? We all know antibiotics do work, right? There's no doubt about it. But after ALTER trial, do antibiotics need to be routine? So the question itself has changed. So yeah, so there's a stewardship era paradigm shift. Older model, yes, continuous bacterial suppression, daily dose, endpoint, feared dysuриas, yes. But what is the new model? So recurrent prevention with minimal ecological injury, because we saw at 8 years of follow-up, we had more patients getting admitted with double the risk with pyelonephritis. So fixing the host should be the first important thing. Hydration should be the important thing that we look into. Cranberries, methenamine, vaginal estrogen, where they are indicated should be the ones. Behavioral and post-coital strategies, they should be counseled well. And antibiotics should actually be reserved, time limited with a stop date. Isn't that what all ID physicians talk about, right? So how would I set this up is, first confirm. that it's a recurrent urinary tract infection and not an asymptomatic bacteriuria. Next, understand the phenotype, because the studies have been done only on the first and second phenotype of pre and postmenopausal women with lower urinary tract infection. So understand the phenotype first. Third is fix your host. Is it voiding issues? Is it glycemia? Is it atrophic vaginitis? Is it post-voidal residue? Is the patient catheterized with a biofilm which is causing the issue? In those situations, please don't waste these antimicrobials. Right? So try antibiotic, non-antibiotic means first pertaining to vaginal estrogen, cranberries, methenamine, etc. And if then also that you're not able to use it, I would rather position the antibiotic prophylaxis in this particular category given for only the pre and postmenopausal females in some area. And when you're, as rightly pointed out, if at all you're giving it, please reevaluate them at 3 to 6 months, stop, switch, de-escalate, but never set and forget. So it should be exception based and not a reflex default strategy based, because actually what doesn't kill us at this point of time will mutate and try to kill us again, right? So the question is whether prevention that creates resistance can still remain the default strategy. Thank you.
Thank you, Divya, for that excellent counterpoint. Now I invite Akshatha for the rebuttal.
So, yeah, I mean, definitely I agree with many points. I mean, that is what we debated for. The reason was to bring both because in ID it's never blacks and whites, it's always the grays. So I do have some points in rebuttal. One thing is, I agree that most of these studies were based in the first and second phenotype you did mention, but what to do in those patients? Those studies which are there for non-antibiotic prophylaxis also do not include this subpopulation. So we are still in the soup with what exactly to do with that subpopulation, including your neurogenic bladder, structural anomalies. I agree we need to screen all these patients, try to correct the structural cause, but till it is getting corrected, till that time, what to do? Do you still want to give a non-antibiotic based therapy or give the antibiotic prophylaxis? So next point would be definitely the concerns with resistance is real. I do agree with that. Saying that sometimes when the study which showed the long follow-up of 8 years, the reason we may be giving the prophylaxis is because these patients are already at higher risk of these recurrent UTIs, which already, or maybe they have still structural abnormalities, which already predispose them to these infections. So that would be a bias. And also with regards to the if they want to look for the resistance, as we all know, especially in the women urethral system, they are more prone for UTIs because of the proximity. So are we actually looking at the resistance which is there actually in the gut, which we all know is predominantly CREs rather than the actual organism which is causing the infection, which may need not be the CREs which we are thinking about. And with regards to the resistance, yes, Cotrim, there was a study which showed increased 90% resistance even with 1 month of therapy. The side effects, yes, these are all real. So low dose, that is why the studies have also explored the low dose alternatives, so which we can minimize the side effects with retaining the effects. And with fosfomycin, my concerns would be like the resistance which is reported in the report may not directly translate, because this is one antibiotic which highly concentrates in the urine. So even though it may be reported as resistance, may actually work because the concentration it achieves in the urinary bladder is like 10 to 20 fold. So I rest my case here.
Yeah, I think we end up agreeing on a lot of things. So the one strategy policy that we talk about, I think I'm not going to repeat again. We're looking at multiple phenotypes, as you rightly pointed out. Use it carefully. If you're using it into those areas, into those phenotype 1 and 2, we're looking at probably the premenopausal and the postmenopausal women, reserve it if at all you have an option. In the current day and age, what option do we have, right? We see all the carbapenem resistant organisms, and what would you give? Would you end up giving fosfomycin if it is resistant? I'm not really sure of that, right? And terrible diarrhea, my friend, terrible diarrhea, trust me, right? So that is one thing which we're looking at. Identify your which phenotype or the umbrella where your patient sits into, and just randomly prescribing into something which was studied in, we don't have the Indian data, right? So which was studied into the, in the Nordic areas, Welsh, UK, US, etc. Because they use cefalexin, they've used amoxicillin clavinic acid, they've used other, even phosphor, yes. And the latest study which spoke about phosphomycin being used, and it was being followed up for 8 years, there was increased and double incidence with a bad upper urinary tract infection with pyelonephritis, which was the concerning factor, right? So I think none of them, one strategy, as I said, would not work for all. Identify your host, identify your phenotype, and then probably end up giving the thing. So this is where it would come at. Hygiene, I would first probably, like as you rightly pointed out, I would make sure that hygiene and behavioral measures is something that I would look into. Correct what's wrong if it's possible to correct. Non-antibiotic means first, and only selective areas, probably just 10% is where I would look at if I have an option. Thank you.
Thank you for that excellent debate. Do audience have any questions? Or we can, how many of you feel at the end of the debate that continuous prophylaxis is recommended for urinary tract infection? For the yes motion. How many of you, okay, how many of you feel that antibiotic prophylaxis should not be given for recurrent urinary tract infection? Okay. But majority of you, I think, are for individualizing patient and as Akshatha has pointed out, precision and not prohibition. I think that is the message everyone wants to go with, where both of you have defended, given the points and counterpoints and evidences. Thank you very much, and a big round of applause for the debate. Thank you so much.
May I request Dr. Kavitha Saravu to kindly present memento to the speakers. Thank you, ma'am. That brings us to the end of our morning session. I thank all the speakers and moderators for beautifully guiding up the morning session.
We would like to thank the audience who have joined online, and we'll come back after the lunch break. Please do join us back.